one just sort of level setting statistic here that I think is helpful, and these graphs actually don't do it justice. If we go back, to the early 1980s, one way to sort of measure what's generally referred to over the last 40 years as healthcare corporatization. So kind of the transfer of power to large corporations and financial investors within our healthcare system. One way I think of measuring that is to look at how physicians and the degree to which they are currently employed by one of the corporate entities, and how much they were historically. So if you go back to the early 1980s, less than 25% of physicians were employed by a corporate entity. And by that, we mean either a hospital system, or a private equity company, or a public, equity company, as they more used to exist as sort of management companies, or an insurance company, which is more pervasive today, or a big, or any sort of corporate entity. We're seeing large, pharmacy retailers really get into this business. I'll talk about that in a second. The overall point being, we used to see much less of this. That number was lower than, or less than 25% in the early 1980s. Today, it's over 75%, and potentially well over 75%. The latest numbers on this, part of the problem here is they're actually very difficult to track. Latest numbers were about 74% at the end of 2021. There's been a raft of acquisitions by large insurance companies, very similar to what we're seeing at Corvallis Clinic right now, of large insurance conglomerates purchasing medical practices, as well as big pharmacy retailers. There's been a huge wave of that. 2023 was really a record year. So the number's probably above 75%, depending on how other sort of corporate owners, how statistics have moved in that regard. But nonetheless, massive sea change over the decades that I think is helpful for orienting kind of where we are. So the biggest player in this historically has been hospitals, and continues to be today. We've seen significant, we're all familiar with large hospital systems, for-profit, non-for-profit. Today, about 50% of employed physicians, again, one way of measuring this, are employees now of hospital systems. And we've seen both what's referred to in legal spheres as vertical and horizontal consolidation. So vertical consolidation, think of, the acute hospital purchasing a local primary care practice or specialty. That's vertical, thinking of sort of the supply chain, I guess, or the delivery system, the continuum of care, versus a horizontal acquisition, which would be like a big acute hospital purchasing another acute hospital. So sort of what we're seeing, or about to see in Portland with Legacy and OHSU. That's going to be a very big merger. I think it's going to be the biggest hospital merger in Oregon's history. So that's a classic case of horizontal consolidation. And these two graphs just sort of illustrate both vertical and then horizontal. This graph actually is sort of an exception to the rule of the few big horizontal acquisitions or mergers that have been stopped by federal regulators. There's really just a few over this goes back to 2007. Again, the large story being policymakers and regulators have really been permissive of consolidation, thinking that, it could bring efficiencies, scale, a lot of the things that, theoretically we might hope happens. But the larger story has been less, I think, of, seamless coordinated care run by, shrewd managers who know how to, efficiently, make care better. More so we've seen, and I think this is pretty non-controversial, particularly in the hospital setting, a increase in the degree to which basically large corporate entities know how to turn profits. And so I've just identified three, I think, well-studied results of sort of on a high level of what we see with hospital consolidation. The first being market power in the commercial market, or the commercial insurance market. Big distinction in sort of our bifurcated healthcare system, about half of spending in public Medicare and Medicaid, half of spending in the employer world. Probably the biggest distinction between the two is in the employer, commercial, private insurance world, prices are negotiated. Whereas in Medicare and Medicaid, they're pretty much set by government entities. So what we see with this consolidation is a real exploitation of the commercial insurance market, very intuitive process here. Ensure big hospital systems become large, they become the only system in a region, they're able to negotiate higher unit prices for their services. We also see monopsony power. So this is the ability, monopoly power would be the ability of a hospital to contract and basically extract rents from a insurance company. The monopsony power is its ability to squeeze its suppliers or its input costs. And the biggest one there is labor, caretakers, and other people, say, in a hospital setting. So we see, again, on aggregate, where there's more hospital concentration, you see lower growth in nurses' wages. Again, sort of an intuitive, process that happens that's borne out in the data. And then three, we see exploitation in different ways of the Medicare program, particularly around some loopholes in the Medicare system. As I said, the prices are generally set, but there are a lot of ways that consolidation actually becomes favorable in the Medicare world. One example would be basically converting an outpatient facility to a hospital outpatient facility. So for a given service that traditionally provided by an independent physician, if it's provided technically in a hospital outpatient department, it's paid significantly more. You get what's called a facility fee. So this is a real incentive for both the independent provider and the hospital to merge, because that basically creates a bigger pot of money. So that's a quick rundown of sort of the hospital context and why we should be concerned when we see big hospital mergers. Second, and this is where I think we've seen interesting acceleration of late, and where more, I think, policymakers are turning their eyes, is the increase in non-hospital corporate entities. And this is both private equity, so basically, privately held finance, and really insurance conglomerates and pharmacy conglomerates. And I'll talk a little bit about each of those just briefly. So the private equity world, I'm not going to get into too much detail here, just to illustrate that really in the last couple of decades, we've seen a significant increase in the amount of private equity investment in healthcare. A couple numbers here: 5 million to 100, billion to 100 billion between 2000 and 2018. 750 billion total. So that was annual total for 2010, 2020. Again, very well documented that the amount of privately held capital that's come into the healthcare system is really significant. And the models that are used here, and this will make more sense when I talk a little bit about corporate practice of medicine bans, but the models that are used are contracting models to essentially allow the private equity company to control the physicians are complicated, and I'll touch on them a little bit in a minute. But this graph is just to illustrate the kind of classic roll-up model we see with private equity investors. So the intention, sort of similar to what I talked about in the hospital setting, is to aggregate market power. This is one of the practices we systematically see. It's the subject of the FTC's historic lawsuit against United States Anesthesia Partners in Texas, which the FTC is suing them and their private equity investor for one of these strategies of basically quote unquote rolling up or consolidating a bunch of anesthesia practices in a given location, getting that market power, and allowing them to basically negotiate really high prices. Again, that's kind of a classic story of what we'd be concerned about with private equity on the kind of price side. And then there's a lot of emerging evidence about some really scary stuff that happens with this particular type of ownership. This is one study from Zuri Song and his group talking about practice acquisitions. You see an increase in spending, charges, prices, and volume. So not only just that negotiating power, but also just having managers pressuring in various ways, administrators and providers to bill more, see more patients, again, drive revenue to maximize profits when they make an acquisition. Currently making some headlines was a study in the hospital context, so private equity actually owning hospitals, and some really frightening statistics around increased basically infections for patients that were statistically significant. Similarly, there was a groundbreaking study in 2018 about private equity ownership of in the nursing home setting, essentially increasing mortality rates by 10%. And the explanation is the same for those two studies that I just cited, as far as the researchers can tell. And it's just a slashing of labor, just cutting nurses, other caretakers, fewer of them around. Again, these are sort of sort of intuitive outcomes. People suffer. So that's a very quick sweep of the private equity landscape. And then this third graph is a good actual segue to the last type of corporate owner that I think is worth paying a lot of attention to right now, because I really think this is kind of the future unless policymakers do something about it. What we see with most private equity is a quote unquote flip or a sell after 5 or 6 years to another private equity company. If they're not selling to another private equity company, what we're seeing is a sell to one of these non-hospital corporate owners often. And the biggest player is Optum or United Healthcare, the massive conglomerate that's both an insurer and now increasingly a provider of healthcare. So that's a good segue, I think, into this last sort of type of corporate owner that I'm sort of bunching together as insurance conglomerates and national pharmacy retailers, because they've been co-consolidating for a while now. And what we're seeing is really now an aggressive consolidation, not just of insurance and pharmacy and the drug supply chain and pharmacy, but also of clinical providers, particularly primary care, home-based care, and home-based care in the post-acute setting as well. So this graph provides a little bit of context before I jump into a few examples and a few names of different conglomerates that I think will be familiar. One thing to pay attention to is just the kind of another sea change we've seen in the healthcare system over the last couple decades, and really in the last decade, is the way that our public insurance companies have been privatized, or excuse me, our public insurance programs have been privatized. It's hard to, privatization is one word for this, and I think is generally apt. Certainly to describe what we've seen with Medicare Advantage. So half of Medicare patients now are in a privatized version of Medicare. This is where the government essentially delegates the total risk of financial care, or basically gives a budget to an insurance company to offer Medicare. And then we've also seen in Medicaid, essentially the same thing has happened in most states over the last 30 years. Really, again, a sea change, a move away from states directly reimbursing providers for care to what's typically referred to as Medicaid managed care. In Oregon, we call them coordinated care organizations. I think initially conceived as being something a little bit different than traditional managed care organizations. But as folks may have noticed, right now our biggest coordinated care organization is about to be purchased by a huge Medicare Advantage company, Scan Healthcare. So here in Oregon, we're kind of seeing an evolution, I think, towards, again, just kind of classic managed care model, which we had before to some degree before the CCO started. That's a whole nother conversation that I'm sure has been had here and we could talk about. But the general point being that Medicaid, it really looks different now than it did certainly 30 years ago, and certainly 10 years ago as well. And then also in traditional Medicare, so the half of Medicare that's not in Medicare Advantage, we're increasingly seeing payment models that really, to a large degree, reflect Medicare Advantage type reimbursement. And this is where less so the capitated budget gets delegated to an insurance company. It actually gets delegated directly to a group of physicians or to a hospital system. And this is where they essentially become mini insurance companies, is one way to think about it, where they're quote unquote taking on the risk of the patient's total costs. And that really puts them in a position to play an insurance management function. And this is this is a super interesting area of policy where there's, I think, really strong feelings on both sides. But I think it's important to show that the similarities between Medicare Advantage and what's happening in traditional Medicare and then Medicaid as well. And all of this, I just say, is a preamble to why we're seeing insurance companies like United Healthcare, like big Medicare Advantage insurance conglomerates, why they're so keen on owning providers, particularly primary care providers, is because in the world of government capitation, it's incredibly lucrative to be able to control primary care providers, not only to increase the capitated budget that is received by that risk-bearing entity, again, that insurance company or that group of physicians, and also to better keep costs below that budget, because that's how you turn a profit. So I think this story has to be told when we start to talk about this vertical consolidation of insurance companies. We have to mention what's going on in public policy, because it's really a huge driver of this consolidation we're seeing, again, by insurance conglomerates purchasing physicians. So I'll just give a few quick examples of companies that might be familiar. United Health Group is the biggest player here. They've been doing this actually for a good decade now. After the Affordable Care Act, they really pivoted aggressively to provider acquisition. So they're now the largest insurance company in the country, and they're also the largest employer of physicians. About 90,000 physicians they own. And this is really focused on primary care, specialty care, even some ambulatory surgery centers, and then also the post-acute world, and particularly the post-acute, non-facility-based post-acute. So particularly home-based care, different hospice providers. This is really where, right now the Oregon is actually reviewing a transaction, as is the Department of Justice, for Optum's purchase of Amedisys, which after its purchase of LHC Group, if the acquisition is consummated, will make them the largest provider of home care in the country as well. And this complements their strategy that's longstanding as well, to control more of the drug supply chain. So United Healthcare, as a conglomerate, owns one of the three big pharmacy benefit managers, and also partners with Walmart and a bunch of other pharmacists to be a part of the pharmacy, of actual pharmacies, as well as pharmacy benefit managers, which basically play a middleman role between insurers and pharmacies, and the actual drug manufacturers. We're seeing a similar strategy between from CVS Health, which is now, as of 2018, purchased Aetna, which is another, I think, the second biggest, or the third biggest Medicare Advantage insurance company is Aetna. CVS purchased them. CVS, you all know, is a big pharmacy chain. And then Aetna really is following the playbook of Optum. We saw just this past year, this is one of these big 2023 vertical consolidation stories, their acquisition of Oak Street Health, a chain of of primary care providers that basically grew out of the Medicare Advantage world. Oak Street Aetna also purchased Signify, which is a company, again, basically a company that arose out of making money in Medicare Advantage. They really focus on health risk assessments in the home. This is part of a strategy around risk adjustment, which is a big story in Medicare Advantage, to basically a way to increase capitated payments in that model. Don't want to get into too many of the weeds here, but again, just kind of want to illustrate the same kind of playbook that we're seeing with at CVS Health as a conglomerate, both and they also own Caremark, which is another one of the three big PBMs. So again, we see this vertical consolidation between the drug supply chain, big insurance companies, and primary care and post-acute providers. And then I won't belabor it, kind of a similar triad emerging here with Cigna, Village MD, which actually has a decent presence in Oregon, and Walgreens. Amazon, similar, although they haven't gotten into the insurance game. They've been doing a lot of work on getting into the drug space, and now increasingly into actually providing medical care. Their acquisition of One Medical, I think One Medical has a reputation for serving younger patients. I think what wasn't quite realized is that One Medical had purchased Iora Health, which is another one of these Oak Street-like senior-based, as they tend to call them, but basically Medicare Advantage companies. And I think that was a big reason. They actually drive about half of the revenue from One Medical now. Another big reason why I think there was a lot of interest in Amazon and getting into this world. So that's a quick overview of corporatization trends. I'm just going to talk really briefly about corporate practice of medicine as a doctrine that could potentially be used by states to prohibit or limit some of this corporate investment. These slides come out of some work that colleagues and I did in New England Journal on kind of just surveying the land or the landscape of corporate practice of medicine bans. Folks may or may not have heard of this before. They've really sort of eroded since the 1970s and 80s, but historically these were bans that were kind of what they sound like. Basically dating back to the 1800s through state medical boards, attorneys general, actually, interestingly, state Supreme Courts, as here in Oregon, and then sometimes through statutes. There's basically laws saying that if you're a lay corporation, just like if you're a lay person, you can't be engaged in the practice of medicine. We're going to say that practicing medicine is different than sort of any commodity in the market, and there's going to be rules around whether lay corporations can control the practice of medicine. What we've seen in since the 70s, and again, I think this ties into this larger trend of corporatization and a decision amongst policymakers and regulators to put corporate entities more in the driver's seat. This was along with sort of the rise of the managed care movement, the thinking that we need private sector, shrewd sort of private sector managers to control medical costs. And I think there's a whole slew of legislation that's sort of consistent with this vision that if we have more of these folks kind of controlling our system, that they're gonna rationalize it for us, as healthcare costs have been basically increasing at a frightening rate since really the 60s. So what we started to see is an erosion of these bans on corporate practice of medicine in a couple different ways. So one was just getting rid of the requirement that licensed medical providers have to be the majority owners of a medical practice. This is typical for a state that has some form of a ban on the corporate practice of medicine, and this is essentially says if you're a type of corporation that's actually allowed to engage in practicing medicine, these are typically through what are called medical practice acts. The statute tends to say that you need to be a licensed medical provider. The majority of your owners, of your shareholders, need to be licensed medical providers. What we started to see is an erosion of that requirement, where either professional corporations or other types of corporate forms that were allowed to practice medicine actually didn't need to be majority owned by medical providers. We also saw exemptions for certain types of providers. Again, HMOs were a big part of this. So wanting to basically, and part of this came through encouragement from federal legislation, basically states saying if you're an HMO, oftentimes non-profit hospitals, now today for-profit hospitals as well, they're regulated in a certain type of way to where states have said, okay, you're not subject to the state, whatever the state's sort of historic corporate practice of medicine ban is. And then the third way, which is the most interesting and probably the most difficult for regulators to try to wrap their arms around, in which I think explains the consistent trend of corporatization, irrespective of the formal ban on corporate practice of medicine in a given state. So as this map sort of shows, Texas and California, interestingly, are thought to have really strong bans on corporate practice of medicine, but we don't see that tending to limit the amount of corporate investment and ownership there is. And that's really gets to this third explanation, which is essentially boils down to very smart and very well-paid lawyers figuring out how to essentially own the medical practice without formally being an owner of that professional corporation or that corporation that I just mentioned that's allowed to engage in medicine. And this is through really sophisticated contracting that's known as the friendly PC model of a given of a corporate owner. And it really comes out of the private equity world. And essentially what it does is it installs the lay corporation finds a physician who essentially will willingly contract with them, and the PC, the professional corporation, will essentially contract away a lot of the duties that really contribute to what it means to be in control of your medical practice. Some of the big ones that you'll see really typically are, a stock transfer restriction agreement, for example, where the medical practice will contract with the lay corporation and basically allow the lay corporation to have control over whether the corporate owners sell their shares or not, or they'll exert some sort of control over hiring and firing, or all the decisions around what is billed in the name of the physicians, or non-compete agreements. So a lot of contracting provisions that, without actually having formal ownership, puts that management services organization or that corporate investor in control of the medical practice. I will, if there's more interest on corporate practice of medicine, I can certainly talk about it, but that was probably enough in the weeds for folks, at least for initial comments. So let me stop there, Mike, and see if folks have questions or want to share anything on any of those topics.
Yes, we have a question in the room.
Questions of terminology. For example, what does capitation mean?
I don't know if you could hear that, but what does capitation mean?
Yeah, thanks for the question. And I think in part it depends on who you ask. The way I think it's helpful to think about it is generally contrasted, and I think it's helpful to think about it in the context of our public healthcare program. So Medicare and Medicaid, traditionally what's referred to as fee-for-service medicine or reimbursement. The state will reimburse a physician for a given service at a set price. Capitation is the move away from that model where the government, say Medicare, essentially pays a private entity, an insurance company, I think is the best example, for their basically the projected cost of every patient, of a given patient, and pays them for an entire year, and pays that capitated rate to the insurance company and allows them basically to design an insurance product, sell it to the patient, and basically quote unquote manage their care. So I think that's how I think about the distinction between fee for service and capitation. I hope that helped to brief a little bit.
Hayden, I'm going to ask you the impossible $1 million question. You've described very well what the problems are. What would you suggest we could do about them? What kind of action do you suggest?
Yeah.
And I'm sorry for throwing that at you. But...
No, and I'd be curious to hear what other folks think as well. So one solution is what I started to talk about here a little bit on corporate practice of medicine. So there's actually a bill right now in Oregon, and there was an attempt in California a couple of years ago to essentially update this doctrine to try to get in the way of this friendly PC model, or try to basically right size it, allow physicians to contract with management services organizations, but not do so in a way that relinquishes control, basically all control over all control of it. So you can, legislatures can pass legislation that basically says, strengthens what we mean by control of a physician practice. Again, a good example of what's going on in Corvallis Clinic. Optum is not actually buying the professional corporation. Through a merger agreement, they're installing one of the physicians at Corvallis Clinic as the sole owner of all the physicians. So everybody but one physician is going to be employed. And then it's contracting part of the transaction. Basically Corvallis Clinic is contracting out basically everything about the practice except for quote unquote medical decision making. So that's an example of this friendly PC model where you could have legislation that said sort of start to set out ways or start to define what we mean by a practice actually retaining control over itself. So that's one way, is essentially strengthen corporate practice of medicine bans. Another way is really what we at least have the infrastructure to do here in Oregon, state regulatory agencies. So HCMO, the Healthcare Market Oversight Board, has the authority to review and block transactions that are going to harm the public in some sort of way. And I think there's regulation at the, much stronger regulation at the federal level to try to address or there could be stronger legislation for enforcement agencies. Again, if we want to think about this as a consolidation problem. And then there's a lot of stuff on the policy side. So depending on the type of consolidation that we're concerned about, if we're concerned about insurance-led consolidation, the first thing would be to pare back or get rid of the Medicare Advantage program. So right now, the government essentially subsidizes the Medicare Advantage insurance program by anywhere from about $80 to $140 billion a year. It's a staggering amount of money. And so when you wonder why Optum has the money or United Healthcare has the money to go purchase these practices, the government is subsidizing them significantly relative to how we subsidize traditional Medicare. And then the last thing I'll mention, and I won't get too far into it, is really thinking about how do we create a system that finances, that makes it easier for practices to practice independently and not be corporate owned, or that are just publicly owned and publicly provide care. And I think this gets into more discussions about folks who are interested in single payer and publicly financed healthcare. Really, what we have to do to stop this stuff is push forward a forward-looking agenda that creates a resilient, publicly owned and provider-owned healthcare system.
Thank you. Fritz, I don't know if you can see if anybody online, I'm not able to see them. If anybody online has a hand raised, would you take a turn calling on folks?
I can take a look. I had actually had my hand raised, and then Hayden spoke to exactly what I was going to say. And I appreciate the fact that he stopped at this slide, because this is exactly what is happening with Corvallis Clinic right now. And it's dangerous. I'll go kind of left to right. I see Keith has his hand up. Keith, please go right ahead.
Yeah, I'll jump in at the Hayden. I appreciate your explanation of the purchase arrangement for Corvallis Clinic. You were right on. I've been involved in that contract negotiation for about 6 months. I think what we need to do is to address the fear is that the ownership is still going to be like a traditional professional corporation. That is, the doctors in that clinic still will own the clinic or operate the clinic. Again, getting under the Corporate Practice Act. And, I think people need to look at it like us attorneys. We all went from sole practitioners to the professional corporation model. And we too were always scrutinized as to who would own and control law firms, and accounting firms went through the same thing. So the medical practice is moving through a transition of going from the sole practitioner in the olden days to who owns the corporation today. So that leads to my real question. And your statistics on who employs doctors needs to be fleshed out a little bit. So the question in Oregon is how many doctors are either sole practitioners or are in their own professional clinics versus the number of doctors who are employees of a corporation. And I haven't seen any of your numbers addressing the distinction between that.
Give me that one more time.
It's the question of who you mentioned, who employs doctors. So
yeah.
The real question here in Oregon is how many doctors are, quote, employed privately versus how many doctors are sole practitioners or are in a clinic organization or a professional corporation.
Yeah, I think that's, I get the distinction you're making. I think, so in Oregon, I don't know. And again, nationally, we actually don't know. We rely on, a lot of these statistics are surveys, and then the statistics like United Healthcare are just what they tell us. From a practice perspective, so you're drawing this distinction between being an employee of a physician-led professional corporation versus one of these other corporate entities. I think the statistics are similar nationally, at least the latest statistics in 2022, actually a bit higher in terms of corporate ownership of medical practices. Was at about 75%. I actually think the statistics is pretty similar. So, for example, the non-hospital corporate entities own about 27% of physician practices. And again, I think that aggregate number, totally defer to anybody in the room if they know, is similar there. But it's a very good question. And one of the biggest problems here with, or one of the biggest interests, I think, sort of on the more academic and scholarly side of things, there's so much interest in trying to just pass laws that create transparency so that we can track exactly what's going on here. The state, for example, the state of Oregon has no idea who owns their practices.
Right.
And nationally, it's very hard to tell too. So at the very least, there's got to be some transparency efforts just so we understand what's going on here, and particularly when you start to talk about private equity and models where you have subsidiary upon subsidiary, it can become very difficult to understand who's actually
kind of
that
interesting.
MSO. So that's my filibustering answer to your good question. I don't know.
I appreciate that. Hayden. Thank you.
Yeah, thank you.
Whoever is speaking in the background, could you mute yourself, please?
Old people who have themselves on
Whoever's laughing, could you mute yourself, please? Okay, Nick, you got another question online?
I'm looking, I thought I saw one pop up at Charlotte Maloney, but I could be wrong.
Well,
I didn't, this is Charlotte and I did not submit a question. Thank you.
Okay.
okay. Alex
Um,
Koff has a question here.
Yeah, thanks, Hayden. You mentioned one of the ways that pricing can be kind of rigged is through facility fees. I've been hit with those myself. That kind of raised my eyebrows. So I was wondering, could you clarify that you mentioned like hospitals take over the clinics? And then, so were you saying that when a hospital like would take over a private clinic, that just by the fact that they're a hospital, that they could charge, that clinic could then charge a facility fee because it's in the hospital network, even though it's not, you know, a hospital, quote unquote hospital facility? Was that correct?
It's exactly right. Yeah. There's, and this has been a known problem for a number of years. Every year there's an initiative to, it's called site neutral payment, which is what it's called for people, for the sort of advocates and policymakers, think tanks who want to fix this. Like anybody who studies the issue is like, you should change this because it fuels consolidation. And again, it needlessly pays, you know, disparate payments for the same exact service and provides this real incentive for hospitals to acquire different types of physician specialties. So it's exactly what you said. It makes no sense from a policy perspective, but hospitals have a lot of money and they lobby the heck out of members to not pass this. Every year it comes up because it's a significant pay for from a budgetary perspective. If you're in Congress and you want to pay for something, if you were able to put this in your bill, you'd save a whole bunch of money because Medicare would no longer be subsidizing hospitals. But they just got a ton of money, hospitals. So they've been able to afford it.
Thank you.
Thank you.
So sorry. So just to follow up. So it's a federal issue. There's nothing we could do on the state level.
Yeah. I don't think that there's, I haven't heard anything creative at the state level. And that's, a lot of these things are difficult because so much of this money is federal. And yeah, with Medicare, this specific problem in Medicare, the Medicare 340B program is another issue where essentially hospitals get, another issue that's thought to fuel consolidation. Hospitals essentially get a large discount on their drug prices when they purchase them. Basically, the government forces them or forces manufacturers to sell at a much discounted rate to hospitals that are 340B qualified. This means that they serve a certain percentage of low-income patients. Really good intentions, great idea on the policy. Hospital, it's been, you know, so many hospitals now are 340B hospitals because, again, really big incentive to basically consolidate in a particular way that gets you over that threshold. And then you can buy medications a lot more cheaply and drive a huge margin on them because you can sell them for the same amount. So that's another program that needs smarter thinking. You obviously want access, you know, to low income providers and hospitals, but it's very clear that it's you know, it's being abused.
Thank you.
Any other, yes, we have another question in the room here.
And then I've got one online.
Okay,
Okay.
Nancy, you may have to speak towards the.
Oh, my name's Nancy, and I worked in healthcare for many, many years before I retired 4 years ago. And now I'm a consumer. I have Medicare.
Speak towards the microphone.
Medicare and I have traditional Medicare and a supplement. So I was wondering if you could speak to the ACOs that are going on right now, because those of us in traditional Medicare in Corvallis, I think most of us are, well, at least with the hospital, because I'm with Samaritan. I got a letter that I've been put into an ACO.
I got one and they asked me to sign it.
Yeah.
I don't think they put me in to
What's
sign
an
it.
ATO?
Belong.
Accountable care organization.
Well,
Yeah.
what care?
Accountable care organization.
How that? Not care.
Well, do you want to speak to that a little bit more?
Yeah, sure. So this is a form of the capitation-based models that I was describing, trying to describe earlier. And the stuff gets so wonky so quickly, and there's so many acronyms like ACOs. So I think a good way to think about it. So we kind of described Medicare Advantage, where the budget for a patient, Medicare patient, I think now costs about on average about $13,000 a year to pay for the healthcare of an average Medicare patient. In Medicare Advantage, that money is given to an insurance company, a United, and then they design a healthcare plan, they design a network, they design a benefit package, and then you decide, I want to be in Medicare Advantage, I want to buy one of those plans. An ACO is a much milder version of this, where you're still in traditional Medicare, so your network is not restricted, and you don't buy a private insurance plan. What happens is, instead of giving that capitated budget to an insurance company, they give it directly to a risk-bearing provider. So in your case, that's the hospital. The hospital has said, okay, we want to be in the hospital. I'm not sure if Samaritan has a Medicare Advantage plan, but the hospital becomes an ACO, and basically says, okay, we're now accountable financially for the total cost of care for you. I think this is less worrisome than the Medicare Advantage world, because you don't implicate insurance companies that can be really sort of vicious in their practices. The idea of the ACO concept is that your primary care physicians, that Samaritan, then are going to be more attentive to your total cost of care, because if they can keep it low, they get more profit. So it's a very market-based model of reducing healthcare costs. And the idea is that the physician is going to have a better incentive. Again, it's a very marketized vision, commoditized vision of healthcare. They're going to have more of a financial incentive, not to give you more services, like was the concern in fee-for-service, but to keep you out of the hospital, for example, which is all well and good if they can see you and keep you out of the hospital. The concern, I think, is when, depending on the actor, Samaritan, we might feel good about, Optum, we might not, or a private equity owned practice, we might not. And this is where I think concern about ownership and who's actually in control here is really important. You could see versions of these ACOs being abused in similar ways as Medicare Advantage. So it's something to definitely keep your eye on. And I think sort of conceptually to understand that these models all are sort of similar in that it's a very sort of commoditized vision of healthcare, where we think the problem is that providers are providing too many services because they make more money doing them. So now we're going to incentivize them to make money by doing fewer of them. Really sort of contentious in policy circles. I have my own sort of feelings about it, but I think the ACOs are less concerning to me than Medicare Advantage, in part because they're less over subsidized, but definitely something to look out for in terms of who's the entity that's taking on that quote unquote risk and basically becoming a version of an insurance company, where they want to keep costs low. You can again think of good ways of doing that, and then you can also think of pretty frightening ways of keeping costs low.
So before we go to the next online question, sorry, Fritz, a follow-up to that. If a person is thrown in, I mean, people are just put into these ACOs, it appears, they just get a letter saying you've been moved to this. How do they get out of it if they don't want it? How do they stop this from happening to themselves?
Yeah. So you might have to change your provider. And this is a conversation to have with your primary care provider. And you really should ask them why they're doing this, how this changes their practice. I bet you most of the physicians will say it wasn't my decision. This was a decision by Samaritan, and you should ask why and what's going to change and why the physicians need, to be incentivized financially differently. Whether they're actually going to be incentivized differently is this. I would just probe. But if you're really frightened about it, sort of at first blush, the way to get out is so it's tied to your medical provider. So there's some decision, either your actual physician or whoever manages them, probably at Samaritan, decided that they were going to do this, and this subjects all their patients to it. and really quote unquote get out of it, you actually see other you need to start to see other providers. And I'm not sure there are many around.
So is yours related? Okay, we have one more related follow-up question, and then we'll go to Fritz.
So there's two problems that I see with ACO REACH. One is that they are able to retain up to 40%, probably no more than 25, but that's still egregious. In terms of administrative overhead, whereas Medicare Advantage is limited to an egregious 15%. So that's a difference that we've learned about ACO REACH. The other thing about, yes, they don't have networks, but the money goes to that ACO. So what is it very likely if I belong to that ACO and the patient wants to go to a specialist outside of the ACO? The ACO has already received the money, that $13,000 or whatever it is. They are not going to be very encouraging for that patient to seek care outside of that ACO. It's going to be very real pressure.
Okay.
Yep, and that's the express intent of the legislation is to give that your primary care provider less incentive, or the incentive basically get that they make more money if they can refer you to a lower cost, cardiologist. And some people would say that's great, like that's how we need to save money. Other people would say the physician or the patient and the physician should be making decisions based on who the best cardiologist is, and there are other ways to solve this kind of cost problem. So totally agree with what Mike said in terms of what the incentives are in this type of model.
Okay, let's go to an online question.
James Maynard has had his hand up for quite a while. James, go ahead and take yourself off mute and ask away.
Actually, this is my wife.
Yeah, actually, it's me, Beth.
Yeah.
But anyway, we came on together. So this may sound ridiculous, but I just want to share what's coming up for me is that I feel like a sheep going to slaughter, and I don't have any way of getting around this. My husband has a Medicare Advantage plan, and that's because he has hearing aids and dental issues and all of that isn't covered by Medicare. I have traditional Medicare, but more and more the people aren't even accepting my Medicare supplemental, which is Regents. And and I was told, oh, Regents, everybody takes Regents, but it's not even true. And I have ended up personally being happy to go to Samaritan because they'll take Medicare. I've tried to go to private physicians. I'm looking for an osteopath. It is so difficult to get a primary care doctor, but you already know this, right? So I'm, trying to go to an osteopath, which is the only kind of medical care that really helps me. And not one of them would take my insurance. What choice did I have but to go to Samaritan? They, thank God, would take Medicare. So I keep gravitating to these monstrously large conglomerates, whether it's Peace Health or it's Samaritan or something, because I have no other choices. So I'm just putting this out there as a consumer who feels like I have no choice but to feed the monster because I don't know what else to do.
Yeah, a lot of the providers will take the Medicare Advantage plan, but not the Medicare.
Exactly. And Samaritan will take Medicare. So the hospitals, when I lived in the Eugene area, I went to the hospitals and they took Medicare. Yeah. So what are we supposed to do?
Best thing I can say is show up to meetings like this.
Yeah, but feel guilty.
Yeah, I mean, you obviously shouldn't. Yeah.
I don't believe in the privatization of healthcare. I believe in the public option, but what public option? So
yeah.
I just wondered what you had to say. What if people feel the same way I do? Yeah. It's almost embarrassing.
Yeah, I mean, what advice do I have to give here on a personal medical level? I will say, I don't think you should feel, I would be less concerned about the personal guilt than just making sure you understand your Medicare Advantage plan, because these plans are can be really complicated to the degree to which they're advertising to you. These are multinational publicly traded companies, so they devise their networks in ways that look enticing to patients, and then might not actually be in your best interest. So oftentimes they'll offer vision and dental, but you'll want to see what happens, what's the network for certain types of specialty care, or if there's a hospitalization, like the things that tend to cost more money, oftentimes people won't realize that the plan actually doesn't cover that.
Yeah.
Now they're also, and this point gets missed, and I think it's hard for people who are sort of more true believers in Medicare to acknowledge. $140 billion is a lot of money. So it's probably the case that on aggregate, for some people, those plans are actually better.
Yeah.
And this gets to this is what you would expect to some degree. Obviously, the insurance companies are taking some portion of that, but the government's paying, again, a staggering amount of money to subsidize these programs. So from a public policy perspective, what we have to do is invest in Medicare, because you're absolutely right. Medicare is not nearly good enough, and we're needlessly subsidizing this private version and introducing a bunch of middlemen who are just taking more money off the top. If we took that $160 billion, by the way, half of it would eliminate poverty tomorrow in America. Again, this is a ton of money. If we put that to Medicare, and again, this is where collective organizing and getting into politics has to be done. Then you could have a much stronger Medicare program, which of course needs to happen. So my only advice would be personally do what you got to do, but just make sure if you do go to the MA plan, you actually know exactly what is there, because they're designed specifically to get people to pick it, and then once they pick it, to obviously reduce their costs, because again, it's being run by an insurance company.
Right, but I feel like I can't be going to private physicians and their practices because they will not take my insurance. So I have no choice about supporting physician-owned practices.
Yeah. I think that, and again, this gets back to the perverse incentives that they face. They are not going to take probably take fewer Medicaid and Medicare patients. Systems.
Well, at least I feel less guilty.
Yeah.
Yeah.
Let's move on to our next.
Real quickly, I did see that Linda Krieger had her hand up, and I know Linda knows a lot about this, so may be able to provide some supplemental information. Linda, are you still out there? There you go.
I am, Fritz. Thanks. Yeah, I just wanted to follow up on the Samaritan ACO Belong Health question. And it's my understanding, and I think I would follow Hayden's advice and talk directly to your physician, but it's my understanding that you don't have to join Belong Health to continue to see your Samaritan provider. And that is because of some new rules that I think were put around the ACO REACH program specifically for 2024 in response to some concerns that were expressed by groups like ours and others about the ACO REACH program. So I also wanted to make the point that Belong Health is the ACO that they're asking you to join. It is a private for-profit company, and it is owned by two investment capital firms, New Enterprise Associates and Maverick Ventures, which are both global venture capital firms in technology and healthcare space. So I don't have any statistics around this, which is unfortunate. I'm a data-based person usually, but my common sense just tells me if a global venture capital firm is getting involved in this, they're making money somehow.
Right, exactly. They're doing this. They're turning us into a commodity.
Yeah.
Right.
So, but I do think that you have a choice this time. This is not, so what the original ACO REACH program used to be that they could put you, you could be put into one of these ACOs without your knowledge and without your consent. But one of the changes that got made for this year is that you have to positively join the ACO.
Linda, we have a follow-up question for you in the room. And again,
Okay.
please speak toward.
Okay, so Linda, this is Nancy Irwin again, and I just got a My Chart. It said after visit summary, and so I went in because I haven't had a visit in months. And it has reason for visit, belong health. So they have put me into it, and I can't figure out how to opt out.
You should be, if you try, there is a, if you go to medicare.gov, you have your medicare.gov account. I think that's where you can opt out. And I think what you have to do, it's a little confusing because what it asks you to do is to say, oh, this is no longer my primary care practice. Now, just because you say that doesn't mean you can't continue going there, but it's telling Medicare that basically that you don't want to belong to this ACO, even though the way it words it is that you say this is no longer my primary care practice.
Evil.
I hesitate to do that because I don't want to lose my primary care.
I understand. I understand. And that's why I said taking Hayden's advice and talking directly to your provider, I think is a good idea. But it's my understanding that you will still be able to see your primary care provider, even if you do not opt into or opt out of Belong Health.
But I don't go to the doctor very often, and my wellness visit's not till October, so, yeah, you know, it's, anyway.
Yeah, trying to get into your doctor is no easy
Yes.
trick right now. Okay, other questions in the room? No? We have another question in the room, and speak towards the microphone.
Sure. I also have Medicare supplemental Plan G. And I've been told, I was told, and I fought back on this, by different people from Samaritan, that they can no longer see me because I'm not in their network after November 1st. So I have made many calls to Samaritan, and finally, Billing and other people at Samaritan have called me back and said, James, you're right. We have to take you, we will take you, don't worry about it. But subsequently to those calls, other people now are calling me from Samaritan and saying, no, you can't come past November 1st to your primary. And it's like, my sense is that the people who are running Samaritan are not being upfront with their own people. Imagine that.
Much less the rest of us out here. But thank God there are people there who are willing to listen to me and dig in and say, oh, you're right, James. They got to take you. Now, just today I got a letter from Samaritan. And I was prepared to send it off to their some address in California that says they need you to fill out, this thing about the.
That's a Medicare letter though, actually.
Well, this was from Samaritan saying, who is your primary care?
I got the same one.
Yeah, how did they read that? How did you read that again? Yeah, have you guys seen this? It came in today's mail.
But do you have a question that you want to pose?
Yeah, well, what I'm trying to figure out is what game is Samaritan playing by having to sign this saying who my primary care is.
Don't sign it.
Oh, what do you think, Hayden?
Oh, what a
Sorry,
hot seat.
is this related to the ACO?
Yeah.
So what that almost certainly is if you sign that, what will happen is that you'll be what's called attributed to the ACO, which means that instead, which means that your physician will then financially have be accountable for your total cost of care. And if you spend more than basically the average historically, then you're going to be a money loser. And if you spend less, you're going to be a money winner. Now, I'll say maybe your physician wants to do this because they're going to give you better care and keep you healthy, and you're not going to spend a lot of healthcare. So I would ask your, I guess no one can talk to their physician these days, but if you can, ask your actual provider why they entered into this and what this changed. But that's almost assuredly what that is. It's called voluntary assignment, and it's where ACOs want you to just sign. So this allows them, this gives them predictability of the patients basically that they're going to have to keep track of, and who will actually determine whether they profit or not. So it's, that's what it is.
Begins to feel a little bit like scam letters that you get in the mail. Yes, Mike.
Yeah, I mentioned before that the major flaw in this system is that they're able to keep so much more money for administrative overhead. And I think Samaritan, I'm thinking of the CEO, Doug Boyson, likes the CCOs that are serving Medicaid, and he sees, and I see it too, they have organized care better than we had before, just fee for service. I suspect that philosophically he sees this potential in the ACOs for Medicare patients. But I also see that the hospital is probably going to get more money out of this as well. It's hard to balance the incentives that a CEO hospital would have in this. The main way to find out is to ask him.
To call Doug myself?
Yeah.
Yeah, lots of luck.
Actually, he has responded well to emails.
Really?
Yes, and I'd be happy to give you his email.
Thank you. I'd love to get that.
Louise Farrell.
Am I correct that the federal government pays out more per person for Medicare, or Advantage than they do for Medicare?
Yep.
Why?
Yes. Because they've lobbied, the industry has lobbied so well to get much higher reimbursement than their actuaries know that they can spend.
Right.
They're very good at that, and then they upcode so that it looks like the patient is sicker than they really are. So they get, instead of $13,000, they get $30,000
Oh.
just by adding code that may not be related to the illness, but maybe they had an abnormal EKG 10 years ago, or they had an allergic reaction, and they can start adding these diagnoses.
Well, it seems as though we should be able to get the federal law so that Medicare and the medical advantage, whatever that's called, are the same.
That's a good point, and we can lobby our president to level the playing field between the two.
Isn't there some kind of oversight group that looks at this?
CMS for the industry.
How about the senators? Can we talk to our senators?
Yeah.
You can talk to them, but you don't have as much money as lobbyists, unfortunately.
And the other thing they can do is they can deny claims. Medicare Advantage makes money denying claims.
Denying claims, right. So there is a question that was posted to the chat from Marnie. It says, do we have objective information on whether the corporatization of medical practices and or medical care results in better health outcomes and or patient satisfaction? I know I've seen studies that say just the opposite, that care results go down, patient satisfaction goes down. What tends to happen in these, and you could see it in that slide that Hayden showed on MSOs, what happens is the MSO, again, they report up, in this case, Optum to United Health Group. You can go out and you can find all sorts of lawsuits that have been filed against both United Healthcare and Optum. And you can find out that providers are given quotas And they have incentives based upon those quotas, so they spend less time with you, and so your quality of care will go down. They will tell the staff at Corvallis Clinic that everything will be fine on staffing, and within the next year, they will start laying people off. Because again, the primary purpose of a CEO is to maximize shareholder value, not to care for patients. So that's what we're running up against.
Thank you. Any last questions for Hayden?
I'm just gonna ask, I have one more.
We're all.
But I don't wanna.
Yeah, Nancy has one last question.
So, and I don't know if you know this, Hayden, or not, but, I mean, I tried to do a bunch of reading before I came about this ACOs, and I knew about REACH last year, but anyway, I did read that you could still go to whoever you wanted to go to, that nobody was gonna control if I wanted to go to, I mean, I know a lot of times doctors want a referral, but I could pick if I wanted to go see a specialist with this ACO. Nobody was gonna keep that from happening, but I don't know if anybody else has had any, I don't trust it, but, you know. But you know anything more about that?
Yeah, that's broadly true. There are ways that, particularly in HCO breach, that providers can contract with certain specialists to basically try to kind of devise a network. But at the end of the day, you're a traditional Medicare patient. You're not in Medicare Advantage, and you can go where you want. So some would say, look, this is the right balance of incentivizing your physician to encourage you to go somewhere. And it's not an insurance company, and that's fine. Others would say, you know, your physician is controlled by a big hospital entity or now an insurance company, and they're incentivized to steer you to lower cost care. That might be worse, and you know, patients tend to listen to their physicians. But it is an important distinction to remember. You're still a original, quote unquote, traditional Medicare member, where the big difference between that and Medicare Advantage is it's supposed to be an open network.
Okay.
One other quick thing from online. I jumped in and answered that last question. Someone asked if Hayden could jump in on the corporatization question and care quality and patient satisfaction.
You got that
so
one.
Yeah, Hayden, your thoughts? I mean, was I spot on, or?
Yeah, I mean, it is. I mean, it's so pervasive now, sort of the corporatization. I think one way to look at it is on the aggregate. Does it feel like care is more accessible? Does it feel like providers are happier and giving better care? Like, what are people's experiences? That's one way to look at it, because again, this is the predominant mode now of delivering care, is through the management of big corporate entities. One other way to look at it is within the corporate entity world. You know, it seems like private equity companies may be particularly bad. That was some of the evidence I showed earlier. The insurance conglomerates, it's more difficult. It's difficult now because this is a much newer practice that we're seeing. So it's hard to say, you know, part of what policymakers have to do now is sort of make a judgment. Do we want these massive insurance conglomerates owning providers? Do we think that's going to lead to better or worse care? It's hard to point to, and part of this gets back to this transparency point of not knowing exactly where they are. It's hard to point to, you know, data at an aggregate level saying, you know, a particular type of corporate ownership leads to this many, you know, deaths or worse care. But I think there's a growing sense that corporatization, sort of what's it providing other than a lot of money for a lot of big corporate entities? It doesn't feel like the system that, you know, patients or providers are much happier. And it's certainly not taking care of what is just a persistent cost problem in this country, where we just spend twice as much as any other country, and we just don't really get much for it. And one unique factor of that is no other country does for-profit medicine like we do. It's totally unique.
Right. Yeah, we're number one in cost per citizen and number 30 in quality. So that's not good. I do want to mention that Keith did post, and he mentioned that he was involved in this contract issue with Corvallis Clinic. He said that's not what's happening to Corvallis Clinic. He's saying there's not a corporatization. I hope, Keith, because you can find plenty of information out there where United Healthcare and Optum have made promises and they've reneged on those promises, whether there's something in a contract or not.
Yeah, I just want to add, and I'm just going to be delicate here. We're not seeing the other side of the coin, and it's the financial integrity of the PC, the professional corporation, is a factor to be weighed in approving or not approving this transaction. So we need to be cautious.
And just so I understand, Keith, your comment about what's not happening there. Well,
yeah, and your last model is more reflective of what's happening. This is not a corporation buying out a clinic. It is still the doctors. It's still a professional corporation run by the doctors is the bottom line.
Yeah, and I'll just make one point on that. We refer to this stuff interchangeably. So for example, in certain states like California, really everywhere private equity is to avoid these laws, it's always what's happening at Optum. The PE company actually is never owning the physician. It's always the contracting model. So I think that's less the distinction versus who's actually in control here. Is this Corvallis Clinic now deciding that they want one physician owning them and they just want to have a different vendor that they contract with? Because that's actually on the face of the law, that's actually what it looks like. We have one owner now of the Corvallis Clinic, and they've just decided to have Optum provide their management services.
And that's the key point. That's the level of inquisition that we need to have here, and it's missed. You're right. Yeah. You're right on.
But I mean, the contract is disclosed. You can see there. I will say that some of the provisions that tend to be more pervasive, that really exert control over the provider practice, don't seem to be in this contract. A lot of it's redacted. But at the very least, it's basically fully relinquishing everything that's not medical decision making. And that's kind of a classic case of what we see where these management services organizations kind of become in the driver's seat, I think is the way to think about it. And as Keith put it, for policymakers, it's a really tricky question of how exactly, what specifically do you permit to be sort of contracted out? I won't belabor that any further. Yeah.
Okay. I think I'm going to call a close to this. And Hayden, thank you so much. You've stepped right into our community at a moment when our community feels pretty ripped apart. So not an easy evening, and I appreciate how well you've handled this. Thank you.
Yeah, absolutely. Thank you, everybody.